Good morning. Dr. Hickerson was unable to be here today, so I am presenting on her behalf. Again, no relevant financial disclosures. Cancer therapy continues to evolve, and vaccines are being studied to decrease recurrence rates in high-risk patients. Particularly in ovarian malignancy, 5-year progression-free survival for advanced ovarian cancer is less than 20%, which makes it a suitable candidate for vaccine development. Vaccine design is based on immunogenic proteins such as tumor-associated antigens, which can be found on both tumor tissue and normal tissue. A tumor-associated antigen found to be overexpressed in both ovarian and endometrial cancer is folate-binding protein, or FBP. FBP is restricted to the HLA-A2 serotype. Expression of FBP is correlated with prognosis, i.e., the higher expression, the worse prognosis. Thus, we proposed designing a vaccine targeting FBP, which led to the development of E39. E39 is an anti-tumor peptide vaccine derived from FBP and is given as part of the primary vaccine series and as a booster. The goal of a vaccine is to be universally applicable, logistically feasible to disseminate, and effective in decreasing recurrence with minimal toxicity. Additionally, it should allow the body to maintain immunologic memory. One concern with E39 was that with repeated dosing, the body would develop tolerance leading to non-response, which is why we created an attenuated form of the vaccine known as E39 prime. These are the immunologic results of our phase 1, phase 2A trial. Patients that were eligible included those that underwent standard of care therapies and were rendered disease-free prior to trial initiation. Patients excluded were those that were receiving immunosuppressive therapies or were involved in other experimental trials at the time. Initially, patients were tested for HLA-A2 status. Patients that were HLA-2 positive were consented for the vaccine. Those that were negative were followed as the control group, and patients who did not consent for the vaccine also comprised the control group. The trial design was a dose escalation. The trial was designed as a dose escalation fashion so that the first 3 patients were given 100 micrograms, followed by the next 3 given 500 micrograms, followed by the next 3 given 1,000 micrograms. However, the 500 and 1,000 microgram cohorts were expanded from 3 each to 8 and 12, respectively, given that the vaccine was well tolerated with minimal toxicity. The vaccine was administered monthly and given with granulocyte macrophage colony stimulating factor for 6 months total. Vaccinated patients then remained disease-free 6 months after the primary vaccine series were then randomized and given boosters. They were either randomized to the E39 or the E39 prime, and these boosters were given at 6 months and 12 months after completing the primary vaccine series. FBP expression was evaluated using the resected tissue from each patient. The slides from the patient underwent immunohistochemistry staining with a monoclonal antibody to FBP. The slides were then scored for FBP expression. Low was 0 to 1, and then high was 2 to 4. We also did delayed type hypersensitivity and ELISpot to evaluate immunogenic response. There were a total of 51 patients included, 29 in the vaccine group and 22 in the control group. Of note, there was no baseline difference in demographics between the 2 groups. 18 patients from the vaccine group were randomized into the boosters, which was again either E39 or E39 prime. Here you can see that the mean delayed type hypersensitivity reaction prior to the initial dose of E39 was 5.7, and after the final dose was 10.3, where R0 is pre-vaccine and R18 is 18 months following the primary vaccine series. Mean overall ELISpot change over time through 18 months was increased by 69.1 when compared to baseline. It was determined during the trial that the 1,000 micrograms was the optimal dose, and when the dosing cohorts were separated, you can see that the 18 months post-vaccine series, that the mean ELISpot increased by 97.1 in the 1,000 microgram cohort, versus a decrease of 57 in the patients receiving a dose less than 1,000 micrograms. At 18 months post-vaccine series, the mean ELISpot in patients with above average initial delayed type hypersensitivity reaction increased by 255 from the baseline, while those with below average initial delayed type hypersensitivity showed a decrease from baseline of 0.75. Immunologic analysis was not significant when comparing the E39 to the E39 prime or in FBP high versus FBP low expression. So in conclusion, E39 demonstrated significant overall immunogenicity on in vivo testing as measured by delayed type hypersensitivity reactions. Ex vivo analysis with ELISpot suggests that E39 is more immunogenically efficacious in patients with baseline immunity to FBP, as indicated by above average initial delayed type hypersensitivity reactions, and in those that were optimally dosed, which again was at 1,000 micrograms. Lastly, the FBP expression level in E39 versus E39 prime used in the booster inoculation did not significantly impact in vivo or ex vivo immunogenicity. Thank you, and I'll take any questions.